Chapter 15, Reassessment. Now you should have your sheets out, your medical assessment sheets or your trauma assessment, doesn't really matter which one you get out. Just so we can keep up with this. We know that if it says reassessment, that means we've already done our primary or preliminary assessment, right? And we've also done our secondary assessment. So our reassessment is what's going to pull it all together for us, as we're continuing our transport to the hospital. So we're going to look at how specifically to perform a reassessment. We're going to look at what we're looking for as far as changes in vital signs. And we're going to look at the difference in how we'll reassess a patient if they're stable or unstable. Do you remember from your reading, how often should you reassess an unstable patient? Every 5 minutes. And how often should you reassess a stable patient? Every 15 minutes. Now that's not set in stone, that's a guideline. If you've got a patient that's very unstable, you actually might reassess them more frequently than every 5 minutes. You might be having to constantly monitor their pulse or constantly monitor their blood pressure, and you might do that every 2 or 3 minutes if you need to. But on the outside, it should be 5 minutes. Actually, it's a minimum. And then for unstable, a minimum of 15. Now, if you only have a 15-minute transport, you're still going to have 2 sets of vital signs. So if it's a 10-minute transport, you're still going to have 2 sets of vital signs. So in that event, just for time and documentation, you would have to do it more frequently. Okay, you got your sheets out. Yeah, okay, that's good. The reassessment basically just goes back and reviews all the steps that you've done prior to that. It's going to start by reviewing your initial assessment. So say you're in the middle of your reassessment and you find that your patient's pulse has gotten too fast or gotten too slow, or you find that their pulse oximetry reading on their oxygen saturation is dropping, then you immediately want to go back to your initial assessment and find out what the problem is or see if you can fix it. Part of the reassessment, you're looking for your trends to see where that's going. Because then, we take our initial vital signs, and then we'll take a second set at some point. But part of our reassessment is we're looking for those trends. And we'll do that by getting even more vital signs. So as I mentioned just a second ago, we're looking for changes, subtle or not. But if you're not constantly reassessing your patient, you're going to miss a change. One thing we know about patients, y'all remember the D word, they're what? Dynamic. They are dynamic. Dynamic means it changes, it's in motion, it's moving. So your patients are always changing. We hope they're changing for the better, but they may be deteriorating. And if it's very subtle, you may not notice it. Looking for deterioration specifically. It's good if they get better, but if they start to deteriorate, we have to step in and try to do something about that. Now, during your reassessment, generally, if your patient is stable enough that you've got the time and the wherewithal that you can go through a systematic reassessment, your patient is probably conscious, they're probably talking to you. So it's a great time to really communicate with your patient. Continue on your path of reassuring them, making them feel better, calming them down, letting them know that you're in charge, you've got everything under control. After just a few minutes with you, they're going to kind of establish a bond with you. They're going to feel very connected. They're going to hopefully become secure and confident in you. And now you've alleviated their fears, but they're going to be at the hospital in a few minutes, and they've got a whole new set of people and things that they're going to have to interact with. So it's a good time to prepare them for what's coming up. We're going to be at the ER in a few minutes, and my partner and I will take you back to one of the rooms that they assign you to. And the nurse will meet us in there, and we'll introduce you and kind of tell her what's going on. And then she'll write that up and do some assessments, and they'll get the doctor in to see you. So that's what usually happens, generally speaking. So you might go ahead and give them that heads up about what's going on, because that also will help alleviate some of their anxiety, and that's important. Part of the reassessment, the beginning of the reassessment will be repeating your primary assessment. Because what are you looking for in your primary assessment?
ABC,
you know, you're basically looking for your ABCs. You're looking for anything that can kill your patient, right? So you're going to constantly reassess that. That's going to be at the top of the list. Looking for life-threatening problems. You're also going to reassess their mental status. Mental status is one of those things that's very indicative of how your patient's doing. That would be a trend that if they had a decrease in mental status, that would be a very bad trend. And sometimes it's a subtle decrease. And part of that communication that I just was talking about in your reassessment, that communication is where you're going to pick up the fact that they have a very gradual diminishing of their mental status. If you had a patient, say, with a head injury, and they were alert and oriented, but say, you know, one of their pupils was a little sluggish, or you saw signs that they'd hit their head, but they weren't showing any real signs or symptoms other than that. But if you notice them having a decreasing mental status during the course of your conversation, like you had told them where you were going to, you know, this hospital or that or whatever, and they said, where are we going? And you just told them that, you know, that should set little bells off in your head that they're having diminishing mental status. So you'd tell them again, and then in a minute or two I might ask them, say, now you know where we're going, don't you? No, where are we going? What did you tell me? So that would indicate that there was a problem. But unless you're in communication with your patient, you're not going to pick up on that. Make sure their airway remains open. Now this probably would be for a patient that's not conscious, that you're having to monitor their airway. Say you had a patient that was unconscious, but they were breathing okay, their vital signs were stable. How would you position them? If they're unconscious, even though their airway's okay, I probably want to put them in a recovery position. Kind of put them on their side so that if they vomit, then they're not going to choke on it. If you got your back turned doing something and they start choking or vomiting. So your unconscious patients that are relatively stable in that their airways are secure, I would just put them on the side. And you don't need to put an oral airway in if you're putting them on the side, because the purpose of putting them on their side, number one, the tongue won't drop back to block the airway, and two, you don't need to worry about them vomiting and keeping an airway open. So if they're on their side, that should clear it themselves, as well as not causing a tongue problem. But if you had an oral airway in there and they're unconscious and laying on their side and they started to vomit, could that be a problem? Certainly. You want to continue to monitor their breathing, the rate and quality. If you have a patient whose breathing rate is changing, that would indicate that, you know, there was something going on that you want to be aware of. Reassess. You're going to be reassessing all their ABCs here. Watch their skin too. Check for skin color. Check for the temperature. That may indicate to you that they're starting to go into shock. And you may have to reset your patient priorities during your reassessment. If you went back during your initial assessment and you noticed that the patient's respiratory rate had decreased from, say, 14 to 10, would that be a concern for you? Certainly. Say you initially you were just transporting what we call with traffic, where you weren't going with lights and sirens, but now you reassess your patient. Now they're breathing 10 times a minute, and their heart rate has gone up to 140 from, you know, 108. Well, you know that your patient is trending which direction? Down. So you may reset your patient priority. After reassessing your patient, going, oh, my patient is not doing well, I think we need to step it up. So you may actually turn on your lights and sirens and expedite your transport. Going to reassess your vital signs. We're looking for trends, right? You're going to compare it to the baseline. You're going to reevaluate your oxygen. You know, make sure that the saturation is remaining fairly constant. If they were tracking along at a 97, 96%, and then you went on and did your secondary assessment, and you're starting your reassessment, and now you see that their SAT is, you know, 94%. So what are you going to start thinking about now? That you're seeing it going down. Say it's 92%. Anything you'd want to do, or do what? All right, say you have them on oxygen and you see that it's going down.
Depending on what it's on, you want me to turn it up a little?
You may. If you had them on a nasal cannula, then you might want to switch them to a non-rebreather. Make sure you have enough. If you've got them on 2 liters on a nasal cannula, you might try them on 4 and see if that takes care of it. What else might you do?
See if it's placed correctly. It might be like falling out or something.
Yeah, make sure that everything is patent there. And if it's a nasal cannula, that you haven't run over the tubing with your stretcher. Mashed it with a wheel. Make sure that your oxygen tank hasn't run out of oxygen, that sort of thing. So you want to reevaluate to see what the problem is. Is it with some of your equipment, or is it something with the patient? That sort of thing. Document your findings. So as soon as you get a new set of vital signs, you want to write them down right away, because you'll forget them. Even with one patient, if you've gotten 3 sets, you're not going to remember all of those. Say this is your 10th call of the day. Patients all start to blend together after a while. So as soon as you get those vital signs, you want to write them down, even though, and I'm the worst one, I think, I can remember that. Like, I know now that if you guys tell me something, I already know I'm not going to remember it, because I've forgotten too often. So now I know that I have to say, send me an email because I won't remember that. Well, same thing here. You're going to think you're going to remember those vital signs, but you're not. So just go ahead and know that about yourself, unless like you're so brilliant you forget nothing. But when you've got so much going on, it's very easy to forget that, and it's too important. So write those down each time so that you can recognize a trend. Think of an example of a problem that might develop into a life threat to the patient on the way to the hospital. We just kind of talked about one. Can you think of anything else? How a patient could deteriorate?
Blood pressure getting closer together, like 80 and 80 over 70 or something like that.
Yeah, did you just read about that?
No, I've just always heard that. You don't want it to
that's
get
called
close.
that's called a decreasing pulse pressure. The pulse pressure is going to be the difference between the top number and the bottom number, and the closer they get, it's usually indicative of a problem. Oftentimes, it's telling you that you've got some type of fullness in the chest. You may have bleeding around the heart sac. Pericardial tamponade is one specifically that we look at when you get a decreasing pulse pressure like this. That's a really good question. You're looking for things of that sort. You're looking to see if their blood pressure is dropping. If you note that your patient that was involved in some kind of trauma, that their blood pressure had been 110 over 70, and now you're checking and it's 94 over 60. What's that telling you? All right, the blood pressure is dropping, and say they're becoming more tachycardic. Any thoughts there? It's bleeding somewhere, either inside or outside, but more than likely they're bleeding somewhere. So it may not be external bleeding, it could be internal bleeding. So you're seeing that transpire and you're going, oh, we're bleeding somewhere.
There's nothing we can do about that if it's internal.
No, but if you're just transporting like with traffic and you start seeing that, then you know now you've got a serious emergency. You're going to have to crank that up and get going a little bit quicker. If you're way out in the sticks, you might consider calling ALS backup for that. But if they're becoming hypovolemic, shocky, their blood pressure's dropping, you want to make sure you've got them on as much oxygen as possible. Remember the other things how we treated last night? Y'all went over shock and bleeding? Yeah. How else did you treat that shock? You're going to cover them up and keep them warm. Why is it important? Or why do they lose body heat when they get shocky? They vasoconstrict. That's part of it. If they don't have enough blood pressure to circulate that blood around, how does our blood get warm anyway? Blood gets warm. Is that how it gets warm? I breathe on it. How do our bodies stay warm? How do we create heat? Muscle. Yeah, the contraction of our muscles create that heat. And so when the blood circulates around our muscles, it picks up heat and then it takes it everywhere else. Well, if it's not circulating well because you have a drop in blood volume, then it's not getting around picking up that heat, and it's not getting it everywhere it needs to go. So your patient's going to get cold So even though you're like burning up because it's 100 degrees or whatever, because you're nervous, they're getting cold. So you got to cover them up. What else you got to do for them? Turn the air conditioner off. You have to keep them warm. What else do you do for somebody that's shocky? We said oxygen. You're going to keep them warm. You want to put them in a position that's going to not put as much stress on their body. So you don't want them standing up. You want to lay them down. Probably more of a, supine, maybe even a low Fowler's. You may do that. Mental status, the mental status could deteriorate. They could have anaphylaxis, which could get worse. Respiratory distress turns to respiratory failure. We were just kind of talking about that. Repeated focused assessments. Now, say you've transporting Granny because she twisted her ankle. What would you be repeatedly focusing your assessment on? Her ankle, her chief complaint. You would still go back and do your initial assessment, but you wouldn't have to do a whole secondary assessment. You'll just do your initial assessment, and then you'll kind of focus on whatever her problem was, provided you're just having to do a focused assessment. Now, their chief complaint may change. You've got somebody that's been in an automobile accident. Their chief complaint was, my shoulder hurts. Well, you're in the middle of a 20-minute transport, and you start going through everything again. Well, now their back's starting to stiffen up. Their neck's starting to stiffen up. So they may get different chief complaints. What are they usually going to complain about the most? Not really a body part specifically, but do what? Well, we're probably going to make them uncomfortable too. They're usually going to complain about whatever it is that hurts them the most. But whatever hurts them the most, is that really the most critical injury?
No.
Maybe not. They can have a spinal injury and they don't feel anything. And that may be their more serious injury. So as they rest, as you get closer to the hospital, they may notice things that they didn't notice before that's kind of bothering them. And that's one of the things that we run into also. When you're interviewing a patient, say at their home, you're asking them what's going on, tell me about this, tell me about that. They don't always think of everything right off the bat. They're nervous, they're anxious. They tell you whatever comes in their mind first, but 30 minutes down the road, they think, oh, I forgot, there's this, there's that. And you'll always find that once they get to the ER, if you ever hear the staff there interviewing the patient, they always say things, and you go, they never told me that. Well, they probably didn't think of it, or you didn't ask it the right way. So, but that can be kind of embarrassing, so make sure you do a good job of interviewing the patient. You don't ever want them to tell the hospital staff something that's important that you didn't think to ask them. Always ask about changes in symptoms. So that scale of 1 to 10, when you're doing your reassessment, if they initially said their pain was 7 out of 10, well, 10 minutes later in your reassessment, ask them again, say, well, how's your pain now on a scale of 1 to 10? You think, is it getting better, worse? How would you rate it now? And so document that. So that'll show that your patient's either getting better or getting worse or staying about the same. Particularly if you've done some type of treatment for them. Oftentimes when you put them on oxygen, that seems to help alleviate their pain, kind of lowers their stress level a little bit. So they may show an improvement in their symptoms based on that. Do your physical exam again just to see if there's any changes. Can you think of any changes that you might be looking for specifically in a physical exam? Say somebody's been in a car wreck.
Or swelling?
Yeah, you may get more swelling, you may get bruising. In fact, that's something specifically in a trauma you want to think about. If you splinted an injury, and 10 minutes down the road, 15 minutes down the road, you're asking the patient, you're re-examining what you've done, your intervention, and you look and you see that their swelling is increasing. You got to be careful that you haven't made that too tight, that you may need to loosen it. Because initially it was a nice snug fit. Now as that part has continued to swell, now it's too tight. It's kind of like your rings and stuff. Sometimes they get too tight and you go, I better get this thing off real quick, or I'm never going to get it off, that sort of thing. And then recheck any interventions. What would be an intervention that you might do, say, for a patient that was in a car wreck? You've put them, you've done a spinal mobilization. What type of interventions might you want to be checking?
A C-collar?
You might check to make sure the C-collar's fitted, that they hadn't any swelling there. Make sure the straps are okay. Make sure if they were bleeding, it's not bleeding through or something like that. Anything else? An intervention. What else would you have done for this patient? Their airway. So, yeah, make sure that the oxygen's still flowing. Make sure that their O2 stat is still good. Make sure their breathing is still the same. Yeah, anything that you've done for your patient, you want to recheck it to make sure it's all still good. This is just showing doing a physical assessment. You want to recheck your interventions to make sure everything is still good. Make sure that your bleeding is managed. Now, say you've put a couple of 4x4s on and you've done a little wrap, your bandage on a place that was bleeding. Then you look at it 10 minutes later and you see that it's bleeding through. How would you manage that?
Change it out.
Pull the stuff off? Start over? Is that what change it out means? Put some more on top? Why wouldn't we pull it off?
And the clot too.
Yeah, if you pull that off, you're going to disrupt the clot. So you don't want to disrupt the clot. So you just put more on top of it, and you might apply some pressure. If you find that it's continuing to bleed quite a bit, then you'll consider a tourniquet. But the tourniquet is going to be to stop bleeding. That you're looking in the short term, your patient may bleed to death. If it's just continuing to ooze a little bit, then I might continue some pressure, put a pressure bandage on there. But if it's just bleeding a little bit, I'm not putting a tourniquet on. Tourniquet is to keep it from bleeding out. Make sure everything's working good. What have we got here? Describe an example of an intervention that might need to be reevaluated and discuss your process for examining it. I think we already did that. Just did that. Your oxygen tank can run out. You can get a line kinked. Watch that reservoir bag on the non-rebreather. Now that's something that you need to be alert for all the time, because if you've got that sealed pretty well on your patient's face, and if the little circle on there, which they're supposed to, those little flaps are supposed to prevent them from bringing in any outside air, if your O2 cylinder is run dry, then pretty soon they're going to suck that bag flat, and they're going to start looking at you. They're kind of going, they're just rebreathing their own air there for the most part. So you don't want to suffocate your patient. So if you notice that bag's flat, you've probably run out of oxygen or you've kinked the hose in some way. The other thing you want to look out for too, if you've got, in your textbook, I think it says set your flow rate for non-rebreather like 12 to 15 liters per minute. I think I mentioned to you earlier. Just go ahead and set it at 15. If you set it at 12, you got to watch that bag all the time, because some of your bigger people may suck that thing dry and you're constantly having to reevaluate. And if you're busy, you just don't have time for that. So go ahead and set it on 15. They're not usually going to suck that thing dry. But it can go up and down a little bit. I mean, it can be just half to 3/4 full, but you want to watch that it's not going flat on you. Okay, you're watching for trends. You'll be redoing your reassessment on pretty much an ongoing basis if you're doing your job. That doesn't mean as soon as you finish it, you start back over. No. But say you've got a long transport time, you're way down in wherever. Where's some faraway place? Beauregard. Is that far? Okay. You're way out in Beauregard, you're transporting up here. So is that going to take you half an hour? Maybe?
Notice the whole will take half an hour.
Notice
Society
the whole
will take an hour.
Okay. Yeah, you got some of those faraway places, then yeah, you will be reassessing. And you might just do it every 10 minutes or so and jot notes down in between, talk to your patient, that kind of stuff. But make sure you keep up with your reassessment. If you don't look at your patient, you're going to miss these things. And I mention this because I've seen a lot of people, they'll do their initial assessment and their secondary assessment, then they go up there and they sit on the airway chair. Now, y'all saw the ambulance the other night, right? You slide the stretcher in, and that seat that's right up behind the driver, that's the airway seat. So sometimes I'll see people, they'll go and they'll sit up on the airway seat. What can you not see when you're sitting in the airway seat? Yeah, you can't see your patient's face. You really can't see much of them at all, particularly if they're, in this position. So you should not be there. That seat is for somebody that's having control of the patient's airway. So if you're sitting up there, then that head of that stretcher better be down and you better be bagging that patient or whatever else you need to be doing there.
Is
If
that
they're
where you
intubated.
sit if you're like we will with one?
Yeah, you'll probably sit there on your clinicals. You may sit on the crew bench, which actually is the crew bench is where she's sitting over here. You may sit on the other side of her so you can see the patient, so you can be there to do a blood pressure or whatever. So it's the better seat, but when you're just riding like on the way to the call, you'll probably sit in the airway seat. Okay, stable, unstable. Yeah, just depending on how bad your patient is. I said if your patient's bad, how often are you going to reassess them?
At least
At least every 5 minutes. If they're stable, you don't have to do it quite so often. All right, we said that. Every 15 minutes for a stable patient, every 5 minutes for an unstable patient or potentially unstable patient. How would you recognize a potentially unstable patient? If you start seeing a trend that they're going that way, if their mental status starts to deteriorate, what if everything looks okay? Everything looks okay. What would make them potentially unstable? Mechanism of injury. Somebody, who said that? Yeah. Mechanism of injury. So they might appear okay, but you know what they've been through, so you know that there's a good chance that they can have a serious injury. So even if they present okay right now, that doesn't mean they're going to stay that way. So for potentially unstable patient, I'm looking for mechanism of injury. Okay, comparing assessments. A stable patient, stable. How would you describe or define a stable patient? Probably about, you could say a bunch of different things.
Mental status.
All right, if the mental status is good, if the vital signs are the same,
Or stay around the same.
yeah, the vital signs are within normal limits, which, what would you say, what's normal limits for respiratory for an adult? 12 to 20 are normal respirations for an adult. How about pulse rate for an adult?
60 to 100.
About 60 to 100. What about blood pressure? Say? Yeah. You know, for a systolic, anywhere from, you know, mid-90s up to about 140. You know, you get above that, you got hypertension. You get below probably the mid to low 90s, then you've got somebody that's probably hypovolemic. And that's going to vary by person too. So what are other vital signs that we're looking for? Oxygen saturation. Yeah, you want it in the, you know, the mid to upper 90s there. You know, if it's below 95, then, you know, there's a little bit of problem there. That would be mild hypoxia, right? What are other vital signs? What were we getting last night? Breath sounds, as long as those are nice and clear. The pupils are equal and reactive. The what?
Blood sugar.
Blood sugar, what do we want the blood sugar to be? 60 to, you know, maybe 120. Now, if your patient is a known diabetic, 60 is not going to get it. They'll need to be at least 70 and above for that to be considered normal. So yes, if your patient has got all their vital signs are within normal limits, all that's good, and you're looking at the mechanism of injury or nature of illness to predict that. So at which point would you determine that they are maybe not so stable anymore? Do what?
If they just start changing.
Yeah, check that trend. If you're seeing movement one way or the other when they've been stable, what about everything is really good, but all of a sudden you're starting to hear your patient wheeze?
Can't breathe.
Has he moved from stable to unstable? Yeah, if he's starting to wheeze, I'm looking more at, if that's a change for you, even though his vital signs basically are the same, anybody with respiratory distress, for me, has moved into the unstable category. Recheck your history. Continue to ask your patient if they're having any changes, what their pain level's like, and that kind of stuff. Every 15 minutes for a stable patient, we're just hoping they stay stable. Your unstable patient, you're constantly looking for changes that could be life-threatening. You'll repeat your vital signs. You'll repeat your trauma assessment if it's a trauma patient, because patients are dynamic. Things will show up later that didn't show up at first, just like a dadgum bruise. If you ever like hit your arm and it looks fine, you look at it an hour later and you got a nasty bruise. Same thing with patients. If they've been in a serious trauma, they may appear fine. That adrenaline that's pumping after that accident may keep them from presenting with some of their unstable vital signs. So repeat your trauma assessment, see if there's anything's changed there. Recheck your interventions. And then about every 5 minutes for unstable patient is a minimum. Okay, reassessment is your last step in your assessment of your patient, right? Assess if the patient's condition changed in any way. If you notice one change, go ahead and do a whole reassessment, because there may be other changes. You know, if they've developed an airway problem, then there may be other things going on too. Check your interventions. Have we said that a few times? I had to put something in here. Okay, what must you do if your reassessment turns up one of these findings? Gurgling respirations. What do we do? Suction. Good work. If the bag on the non-rebreather mask collapses completely when the patient inhales.
Change air.
Yeah, you need to crank that up more, or else your tank's running out of air. And if you can't figure out why it's collapsing, I'm taking it off, because if it's collapsing every time they're taking a breath, they're not getting adequate air. How about snoring respirations? Yeah, you do what? Yeah, the airway is being compromised in some way. What's the most common cause of snoring respirations? The tongue. So you either, if you don't have an oral airway in, you need to put one in, or if it's positional, you know, if the head is like this, you need to make sure you tip it back to open that airway up. That wasn't too bad, was it? Y'all see the point of this little picture? He kind of blends in, doesn't he? Same thing with your patients. You've got to really look to notice changes for your patient.
You like frogs,
Well, I don't mind frogs. Who was it last week that said they hate frogs?
I was thinking about it.
Yeah.